My name is Sheena and I will be performing a head-to-toe assessment on Akila. After washing my hands and obtaining patient consent, I will then begin the assessment. I will start by examining her general appearance, starting with skin color. The color tone should be even. Pigmentation, including pallor, cyanosis, jaundice, and erythema, varies depending on genetic background. There should be no signs of observable lesions, and skin should be intact. I will now ask the patient to stand and observe her posture, noting her capability of standing comfortably erect and inspecting for normal plumb line. Next, I will assess her general mobility by asking the patient to walk, assessing her gait and taking note of a smooth, balanced walk with symmetrical arm movements. The patient's gait should also be shoulder-width apart with accurate foot placement. I'll now assess the patient's range of motion by asking her to move her head slowly from right to left and up and down. I will then ask her to raise and lower her shoulders and extend her arms forward and then in the air and to the side with bent elbows. To assess for hip mobility, I will look at her knee and ankle by asking the patient to extend the lower leg, point and flex her feet, and place feet flat on the floor. Normal findings of range of motion should flow smoothly and be coordinated. Abnormalities of general mobility would consist of staggering, shuffling, limping, difficulty stooping, and limited, jerky, uncoordinated movements. I will then proceed to the head and face. First, I will inspect for symmetry, specifically assessing cranial nerve 7 by looking at her eyebrows, palpebral fissures, nasolabial folds, and sides of the mouth. Abnormalities would reveal asymmetry, abnormal swelling, involuntary facial movements, or tics. I will then palpate the temporal artery for normal pulsation and feel for abnormal tenderness or firmness. I will then palpate the temporomandibular joint as the patient opens and closes the mouth for crepitus and restriction. Next, I will palpate the frontal sinuses and maxillary sinuses by placing the thumbs over her eyebrows and zygomatic arch and push and ask the patient if there is any tenderness. Indications of abnormal findings may signify allergies or sinusitis. I will now proceed to the eyes. First, I will test visual fields by confrontation, which is cranial nerve 2, to assess for peripheral vision. I will ask the patient to remove her glasses as it may cause visual field alterations. Patient and examiner should have their knees almost touching and eyes at the same level to ensure accuracy. The patient will cover her eye as I cover the other eye. To test for peripheral vision, I will move a pencil slowly into her periphery and she will say now once she sees the object. To check for temporal direction, I will start by placing the object behind her head and measuring the angle anteroposterior axis of the eye to the peripheral axis. Normal angles are 50 to 90 degrees. To test for extraocular muscles, I will shine the light towards the person's eye, approximately 30 centimeters or 12 inches away, and ask the patient to stare into the distance, noting reflection of light in corneas. Normal findings should note the light to be in the same spot on each eye. This tests for deviation of alignment from eye muscle, weakness, or paralysis. 6 cardinal positions of gaze, cranial nerves 3, 4, and 6, would be assessed to elicit any muscle weakness during movement. I will ask the patient to keep head stationary and instruct her to follow movement of my pencil approximately 12 inches away with only her eyes. In clockwise fashion, I will move to each of the 6 positions and back to the center with each. Normal response is parallel tracking of the object with both eyes. I will now inspect the external eye structures, taking note of the patient's ability to move around the room and assessing the patient's ability to avoid obstacles and facial expression. Abnormalities include groping with the hands, squinting, and craning forward. I will look for symmetry between two eyes and her eyebrows. Also, I will observe the eyelids and noting if their normal overlap part of the iris when open and are able to close fully. No redness, swelling, discharge, or lesions are noted. Next, I will assess the patient's eyeballs and make sure they are aligned normally into their sockets. I will ask the patient to look up to assess the conjunctiva and sclera. I will note the color change, swelling, or lesions. Normal is china white. If patient is African American, gray-blue is also normal. In African Americans, yellow spots, fatty deposits, and small brown macules on the sclera are also normal. I will now test the pupil, the size response to light and accommodation. I will determine the pupil size normal is from 3 to 5 millimeters. Normal pupils are round, regular, and equal sized. A small number of the population normally have two different size pupils. Papillary light reflex. I will darken the room to dilate the pupils and ask the patient to stare into the distance, advancing the light from the side and noting the response. Normal response is constriction of both eyes, detecting both the direct and consensual light responses. Now on to the ears. I will inspect the external ear, the position and alignment, the skin condition, and the auditory meatus. I will assess the patient's ear for position and alignment and that it is of equal size and that there is no signs of swelling or thickening. I will assess the skin of the ear, noting that it is intact with no lumps or lesions and that the skin of the ear is consistent with the patient's facial skin color. I will assess the auditory meatus, noting the size of the opening and that there is no signs of swelling, redness, or discharge. I will move the auricle and push tragus for tenderness. It should feel firm and movement should cause no pain. With an otoscope, in this case a pen light, I'll choose the largest speculum that will fit comfortably. I will inspect the canal, then the tympanic membrane for color, position, landmarks, and integrity by pulling the pinna up and back for adults and older children and down and back for infants and children under 3 years old. I will tilt the patient's head slightly away towards the opposite shoulder. To test for hearing, I will use the whispered voice test. I will ask the patient to cover one ear, 1 to 2 feet away, covering your mouth and whispering 3 letters or numbers and repeat with other ear. Passing is identifying 3 of the 6 numbers and letters. Now on to the nose. I will inspect the external nose for symmetry and lesions. The nose is symmetrical in the midline and proportion to other facial features with no signs of deformity, asymmetry, or skin lesions present. I will inspect the facial symmetry for cranial nerve 7, noting the symmetry of eyebrows, the palpable fissures, in other words, the opening of the eyelids, the nasolabial folds, and the size of the mouth. There are no signs of abnormal facial structures or abnormal swelling and involuntary movements. I will now test the patency of each nostril by pushing each nostril wing shut with my finger while asking the patient to sniff inward through the other nares, noting no signs of obstruction. I will then inspect the nares, the nasal mucosa, the septum, and the turbinates. Because I do not have an otoscope, I will be using a pen light for this part of the assessment. By lifting up the nose with my finger, I will view each nasal cavity while the patient's head is erect and when the patient's head is tilted back. The nasal mucosa should be moist, normal red color, and smooth, taking note of discharge, bleeding, or foreign body. I will then inspect the septum for signs of deviation, noting if airflow is obstructed, perforated, or bleeding. I I will then inspect the turbinates, which are the bony ridges curving downward from the lateral walls. The turbinates should be light red in color and same as the nasal mucosa, taking note of any swelling or polyps. Now on to the mouth and throat. With my pen light, I will inspect the mouth, the buccal mucosa, teeth, gums, tongue, floor of the mouth, the palates, and the uvula. I will inspect the patient's buccal mucosa, noting color, nodules, or lesions. It should look pink, smooth, and moist. In dark-skinned people, patchy hyperpigmentation is common and normal. I will observe the teeth and the gums by examining for disease, absent, loose, or abnormally positioned teeth. I will check to see if the teeth are clean and white and free of debris and decay. I will then ask the patient to bite as if chewing something to observe the alignment of the upper and lower jaw, noting that the upper teeth rest directly on the lower back teeth and in front. The upper incisors is slightly in front of the lower incisors. I will examine the gums for pink or coral with dotted surface, noting that they are tight and well defined with no signs of gingival margins, bleeding, swelling, or discoloration. I will then check the tongue for color, moisture, surface characteristics. The tongue should be pink and even. The dorsal surface of the tongue should be roughened from papillae, also known as the taste buds. A white coating may be present. I will then ask the patient to touch the roof of their mouth with their tongue. The ventral part of the tongue should view veins and saliva should be present. I will then shine my pen light up to the roof of the patient's mouth to assess the palate. The hard palate is white and irregular, transverse rugae. The soft palate is pink, smooth, and upwardly movable. I will now inspect the uvula by asking the patient to say ah, noting the soft palate rise in the midline, which tests for cranial nerve 10, or the vagus nerve. It normally looks like a fleshy pendant hanging in the midline. I will grade the tonsils if present. With my light, I will then check the tonsils, which should appear the same color of the oral mucosa. To check the grade of the tonsils present, 1 is considered visible, 2 is halfway between tonsillar pillars and uvula, 3 is touching the uvula, and 4 is considered touching each other. 1 and 2 are considered normal in healthy people. I will now ask the patient to stick their tongue out to test for cranial nerve 12. To test for cranial nerve 12 or the hypoglossal nerve, I will then ask the patient to stick out their tongue. It should protrude in the midline, noting any signs of tremor, loss of movement, or deviation to the side. If necessary, you can bimanually palpate the patient's mouth. Now on to the neck. I will palpate the cervical lymph nodes using circular movements of my finger pads. If any nodes are palpable, I will note their location size, shape, mobility, and tenderness. I will now inspect the carotid pulse, one side at a time. I will feel for contour and amplitude of the pulse. Normal contour is smooth with rapid upstroke and slower downstroke, and normal strength is +2 or moderate findings should be the same bilaterally. If indicated, I will listen for the carotid bruits, blowing or swishing sounds indicating blood flow turbulence. Normally, none is present. I will have the patient keep their head in a neutral position and lightly apply the bell of the stethoscope over the carotid artery at 3 levels of the angle of the jaw, the mid-cervical angle area, and the base of the neck. I will avoid excessive pressure of the stethoscope because it can create artificial bruit. I will now palpate the trachea in the midline and palpate for tracheal shift by placing the index finger on the trachea in the sternal notch. The space should be symmetrical on both sides, noting any deviation from the midline. I will now test range of motion and muscle strength against resistance by instructing the patient to have their head forward and back and their head turned to each side and
side to side
by shrugging their shoulders to test for cranial nerve 11. I will palpate the thyroid gland posterior approach. I will move behind the patient and ask the person to sit up straight and then to bend the head slightly forward by using the fingers of the left hand to push the trachea slightly to the right and curve their fingers between the trachea and the sternomastoid muscle, asking the patient to take a sip of water. The thyroid moves up under your fingers with the trachea and larynx as the person swallows. The procedure is reversed for the left side. Now on to the chest, posterior and lateral. I will inspect the posterior chest, the configuration of the thoracic cage, the skin characteristics, and the symmetry of shoulders and muscles, noting the shape and configuration of the chest wall. The spinous process appear to be in a straight line. I will note if the thorax appears symmetrical and elliptical in shape, and the scapula are placed symmetrically. I will now note that the muscles of the neck and trapezius are developed normally for age and occupation. I will assess the patient's skin color and condition should be consistent with the patient's genetic background and take note of any lesions present. I will now palpate for the symmetric expansion by placing the hands on the posterior lateral chest wall at the level of T9 and T10, by pinching the skin between thumbs and asking the person to inhale. The thumbs should move apart symmetrically and note any lag in expansion. I will assess the tactile fremitus by using the palmar base of the fingers or the ulnar edge of the hand by asking the patient to say 99 as you touch the posterior chest wall.
99.
Vibration should feel the same in corresponding areas. I will assess also for lumps or tenderness by palpating the chest wall. I will auscultate breath sounds by comparing side to side in upper and lower lung fields, noting any adventitious sounds. I will ask the patient to inhale by breath through their mouth as you touch the stethoscope to the chest wall. Now on to the anterior chest. I will inspect the patient's respirations by assessing if breathing is automatic and effortless, regular and even, and produces no noise. I will note that the chest expands and contracts symmetrically. I will assess the skin characteristics that are consistent with genetic background and age, noting any lesions. I will assess tactile fremitus by using the palmar base of the fingers or the ulnar edge of the hand and ask the patient to say 99 as you touch the chest wall. Vibration should feel the same in corresponding areas. I will palpate the anterior chest wall for lumps or tenderness, taking note of skin mobility, turgor, skin temperature, and moisture. Now on to the heart. I will ask the person to lean forward and exhale briefly. I will auscultate the cardiac base for any murmurs using the diaphragm of the stethoscope at the left second intercostal space and down the left sternal border to the apex for the high-pitched, soft-blowing, early diastolic murmur of aortic or pulmonic regurgitation. I will now assess the upper extremities. Range of motion and muscle strength of hands, arms, and shoulders was done earlier in this demonstration. I will palpate the epitrochlear nodes found on the inside of the upper arm just above the elbow. To examine, I will cup the patient's elbow in my hand, the left elbow with right hand and vice versa, and palpate just above the elbow along the inside of the upper arm. When inflamed, the nodes become large and tender. Now on to the heart. I will inspect the pericardium for any pulsations or heave and have the patient sit at a 45-degree angle with the shoulders horizontal, looking for scars, visible pulsations, and chest deformity. I will lay my whole hand flat over the pericardium to obtain a general impression of the cardiac impulse. Then I will palpate the apical impulse and note the location by using one finger pad, asking the person to exhale and then hold it.
Exhale.
You may need to roll the patient midway to the left to find it, but that can displace apical impulse further to the left. Note location should occupy either the fourth or fifth intercostal spaces and be at or medial to the midclavicular line. It should feel like a short, gentle tap. I will then palpate the pericardium for any thrills or palpable vibrations with the pads of the fingers at the apex and left and right sternal edges. I will auscultate the apical rate by listening over the apex for 1 full minute and noting the rhythm. I will auscultate with the diaphragm of the stethoscope to study heart sounds inching from apex up to the base or vice versa. Now on to the abdomen. I will inspect the contour symmetry, the skin characteristics, the umbilicus, and pulsations, and note any localized bulging, visible mass, or asymmetric shape. I will ask the patient to take a deep breath to assess for any change in symmetry. The umbilicus is at the midline with no signs of discoloration, inflammation, or hernia. Skin should be smooth and even with consistent coloring. Striae may be present, which is a normal finding. I will then auscultate bowel sounds, the 4 quadrants, by listening for high-pitched gurgling occurring irregularly, and listen for 5 minutes. If no sound is heard, then bowel sounds are absent. I will then auscultate for vascular sounds or bruits over the aorta and renal arteries by noting the location, the pitch, and timing of sound. I will palpate by lightly palpating in all quadrants, using 4 fingers to depress the abdomen 1 centimeter by making gentle circular motions to get a general impression of skin surface and superficial musculature, saving tender areas. For last note, voluntary guarding. Then deep palpation in all quadrants by applying pressure to depress the abdomen 5 to 8 centimeters, moving clockwise. I will then palpate the liver by placing left hand under person's right back parallel to their 11th and 12th, and lift up by placing the right hand on patient's upper quadrant with fingers parallel to the midline, by pushing deeply down under the right costal margin, and ask the patient to breathe slowly, moving 1 to 2 centimeters as they breathe. Usually the liver is not palpable, but you may feel the edge of the liver during inhalation. And palpate the spleen by placing the left hand under the person's left back parallel to their 11th and 12th, and lift up using the right hand to palpate the left upper quadrant, and push deeply under the left costal margin and ask the person to take a deep breath. There should be no firmness noted. I will palpate the kidneys by using both hands for deeper palpation and ask the person to take a deep breath. The lower pole of the right kidney may usually be felt as a round and smooth mass, but normal findings would be absent of firmness. Now on to the lower extremities. I will inspect the symmetry, the skin characteristics, and hair distribution. I will palpate the following pulses: the popliteal, the posterior tibial, and the dorsal pedalis. I will palpate for temperature and pre-tibial edema. I will separate the toes and inspect. I will inspect for range of motion and muscle strength of the hips, knees, ankles, and feet done previously in this demonstration. I will ask the person to sit up and dangle the legs off the bed or the table. Now on to the musculoskeletal. I will ask the person to sit up and dangle the legs off the bed or the table. I will note muscle strength as the person sits up. On to neurological. To test sensation of superficial pain, I will use sharp and dull for this demonstration. I am using a pencil to act as the dull to test for general responses at irregular intervals, and light to touch in selected areas on face. Ask the person to close their eyes and say now when they feel cotton on their face, arms, hands, legs, and feet. And you can also test vibration by using a tuning fork over bony prominences. I will test the position, sense of finger, one hand, and have the patient close their eyes. I will ask the patient to tell me which way it moved. To test for sterognosis, using a familiar object, I will ask the patient to keep their eyes closed and ask them with one hand to identify the object.
Tell me what this object
To
is.
test for cerebellar function of the upper extremities, I will use finger to nose test or rapid alternating movements test. To test for cerebellar function of the lower extremities, I will ask the person to run each heel down to the opposite shin. Additionally, I will inspect the legs for varicose veins. Furthermore, when assessing the musculoskeletal system, I will ask the patient to walk across the room in his or her regular walk, turn, and then walk back toward you, heel to toe fashion. I will ask the person to walk on their toes for a few steps, then to walk on their heel for a few steps.
Now walk on your
I will
heels.
stand close and check the Romberg sign of proprioception. I will have the patient look straight ahead with feet together and hands to the side and watch for excessive swaying, and then have them close their eyes and again watch for excessive swaying. I will ask the person to hold the edge of the bed and perform a shallow knee bend, one for each leg at a time. I will stand behind the patient and check the spine as the person touches the toes to check spinal curvature and range of motion. I will stabilize the pelvis and test range of motion of the spine as the person hyperextends, rotates, and laterally bends. I will ask the patient to bend sideways, bend backwards, and twist the shoulders to one side and to the other. And that concludes my head-to-toe assessment.
Thank you.